The purpose of this lecture is to review rhythm recognition and dysrhythmias that you had in adult. I also will be introducing a couple of new dysrhythmias that you will need to recognize and be able to treat. As we review, it's important to remember that there are very specialized properties of cardiac cells, and they include automaticity, excitability, conductivity, and contractility. This slide is an illustration of the human heart with the parts of the conduction system labeled. It's very important that you review this and understand it, as the pathways of conduction are very important to dysrhythmias and how the autonomic nervous system controls conduction through the heart, using the parasympathetic nervous system to slow the heart and the sympathetic nervous system to speed the heart. An electrocardiogram, abbreviated either EKG or ECG, is a graphic representation of electrical impulses moving through the heart. The waveforms are impulses moving through the heart. The waveforms of the EKG represent electrical activity produced by the movement of the charged ions across the membranes of the heart cells. This slide shows the graphic representation of a single heartbeat. The P wave represents depolarization of the atria. QRS complex indicates depolarized ventricles. The U wave, if present, may represent repolarization of the Purkinje fibers, or it may be associated with hypokalemia. The PR, QRS, and QT intervals reflect the time it takes for the impulse to travel from one area of the heart to another. This slide shows you the picture of the 12-lead EKG. This particular 12-lead EKG is a heart in normal sinus rhythm. This is the view of how leads are placed on a patient's chest in order to get the EKG rhythm that we're looking for. Figure A shows lead placement for V1 using a 5-lead system. V1 is the chest lead, LA is the left arm, LV1 using a 5-lead system. V1 is the chest lead, LA is the left arm, LL is the left leg, RA is the right arm, RL is the right leg. B shows a typical EKG tracing in V1. I know you covered this in depth in adults, so just to review, this is a 6-second strip with each notch at the top representing 3 seconds. The boxes on the graph paper also represent increments of time. The large box is 0.20 of a second, with the small boxes inside representing 0.04 of a second. When you look at a 6-second strip, you should be able to count the number of QRSs in that 6 seconds, multiply it by 10, and that will give you heartbeats in a minute. You can also do this by counting the small squares between the R to R interval and dividing that into 15,000, or the number of large squares between the R to R interval and dividing the number into 300. Both of these will give you the heartbeat for 1 minute. I encourage you in clinical to practice this by looking at your patient's EKG strip and counting this out. You'll then be able to read the heart rate on the monitor or on the printed graph paper and see how close you are using this method. When we look at this strip, we can see that the rhythm is regular and we can count the QRS waves. That lets us determine that the heart rate is an estimated 90 beats per minute using the 6-second strip method. On this slide, we see a picture of artifact. Artifacts are distorted signals caused by a secondary internal or external sources, such as muscle movement or interference from an electrical device. Artifacts are extremely common, and knowledge of them is necessary to prevent misinterpretation of the heart's rhythm. One of the things that can contribute to artifacts is poor connection between the electrode. Some of the things we can do to improve the connection is clip excessive hair on the chest wall, gently rub the skin with a dry gauze, creating a little friction area. We may need to use alcohol for oily skin, and then we can apply the electrode pad after we've done these steps. For patients with cardiac dysrhythmias or the monitoring, that's an observation of both the heart rate and the rhythm at a distant site. We can have centralized monitoring systems where all the patients that are on monitoring are watched from a single area, and that information is reported back to the nurses caring for those patients. Or we can have advanced alarm system alerts that provide different levels of detection of dysrhythmias, ischemias, and infarction. We see these mostly in the ICUs, where the nurses are responsible for direct observation of the rhythms and or dysrhythmias and or alarms that are displayed on the cardiac monitor. These are just the elements we expect to see. We actually saw a picture of normal sinus rhythm back on slide 11 if you want to go back and review that. This is sinus bradycardia. Everything about the QRS looks normal in this rhythm, except the SA node fires less than 60 beats per minute. So our rate can be anywhere from 40 to 60 or less. Anywhere from 40 to 60 or less. Sometimes patients are asymptomatic with this rhythm, such as athletes, but if they are symptomatic, manifestations will include hypotension, pale, cool skin, weakness. They may have angina, they may be dizzy, they may be confused, or have shortness of breath. Any offending drugs, if they are a side effect of drugs, using IV atropine, and then finally a pacemaker. If the patient has poor cardiac output, we might include dopamine or epinephrine. Let's talk about sinus tachycardia. Sinus tachycardia is a PQRST complex. Sinus tachycardia is a PQRST complex greater than a rate of 100. Sinus tachycardia can be an expected physiologic compensatory mechanism to things like fever, stress, dehydration, fear, and so on. It can also be caused by vision. Drugs can increase our heart rate. Some of the manifestations in symptomatic sinus tachycardia are dizziness, dyspnea, hypotension, and angina in patients with coronary artery disease. This is the image of sinus tachycardia, and treatment is going to be based on what's causing the change, whatever the stressor or the stimulus is. Some example might be to give an antipyretic to a fever or to give fluids to someone who is dehydrated. One of the subgroups of sinus tachycardia is supraventricular tachycardia, which we'll talk about more in a little while. But in that case, we might use drugs, vagal maneuvers, or even cardioversion to try to change that rate. Premature atrial contractions is a PQRST complex that comes a little earlier than when it would have been expected in a regular rhythm. This is shown by the arrows on the rhythm strip, and you can see that these PQRST complexes expected in a regular rhythm. This is shown by the arrows on the rhythm strip, and you can see that these PQRST complexes appear just a little earlier than they should. This slide gives you some of the causes of premature atrial contractions. Most of the time, patients say they can't feel these. If they can, they might. What are we going to do? We're going to monitor these. If they're caused by some kind of stimulus, we're going to withhold that stimulus, and by stimuluses I mean like caffeine or something like that. If they are significant, then we might start the patient on some beta blockers. The next rhythm we're going to talk about is paroxysmal supraventricular tachycardia, that is seen often intermittent with normal sinus rhythm, which is why it's called paroxysmal. You also have just plain supraventricular tachycardia, which is the same rhythm, but it's sustained. The onset for this is often abrupt and triggered by a PAC. It can be associated with stimulant, stress, sometimes deep inspiration, digitoxicity. It can even be triggered by things as simple as coffee or chocolate, anything with caffeine. In the rhythm strip in this slide, you can see the PSVT. There was normal sinus rhythm before and normal sinus rhythm after. The PSVT is the section rhythm before and normal sinus rhythm after. The PSVT is the section between the two arrows. Technically, PSVT is a heart rate between 151 to 120, but any heart rate greater than 180 leads to decreased cardiac output, and the patient may have symptoms like hypotension, palpitations, dyspnea, and angina. Although we say that the rate is 220, I've seen PSVT that's even faster than that. So what are we going to do about this? As I said in a previous slide, we might try things like vagal stimulation. This is where there's massage done of the vagus nerve. It's called carotid massage, or we ask the patient to bear anything else that might stimulate the vagus nerve. We can use drugs like adenosine or beta blockers or calcium channel blockers. If none of that works, we move on to synchronized cardioversion. So now we start talking about the atrial rhythms, atrial flutter and atrial fib. This slide shows you atrial flutter. In fact, there's a big F over the flutter. In fact, there's a big F over the flutter beats. Atrial flutter is a problem at the atrium. You do not always get a ventricular response. If you look at the QRS, it is actually kind of a normal beat. In fact, in this 6-second strip, you can see that the QRS is only beating 60 times a minute, but the atrium is beating much faster. In flutter, it looks like this regular kind of pattern in between, and we often talk about this in terms of the number of atrial beats to QRSs, so a 4-to-1 conduction or a 3-to-1 conduction, something like that. 4-to-1 being 4 atrial beats for every 1 conduction. Okay, so what are we going to do about this? As with all dysrhythmia, the goal is to convert the dysrhythmia back to normal sinus rhythm. We can do this with either chemicals or electrical. So I refer to it as chemical conversion or electrical conversion. Chemical conversion is the use of the pharmacological agents. Electrical conversion is the use of electricity. And then there's certainly the option of radio frequency ablation if none of those work. Next, we'll talk about atrial fibrillation. Unlike atrial flutter, which has a regularity or a pattern to it, atrial fibrillation is chaotic fibrillation kind of pattern. You can see the small f's up on the picture of the rhythm strip that shows us this baseline, grossly irregular pattern that doesn't have any structure to it. Now, the QRSs do have structure, very similar to what we would expect, but they are irregular. This is because only some of the P wave impulse is actually strong. This is because only some of the P wave impulse is actually strong enough to generate the QRS. Again, what is our treatment? We can use chemical conversion or electrical conversion. We would anticoagulate these patients because when the atrium is in fibrillation, clots can form, causing a heart attack or a cerebral vascular accident. The next thing we're going to talk about are junctional dysrhythmias. Junctional dysrhythmias start at the AV junction instead of at the SA node. Therefore, basically what you see is a QRS with no P wave at all. Basically, the SA becomes the pacer. These are associated with disease and certain drugs, but if for some reason the SA node isn't working, this serves as a safety mechanism and should not be suppressed. Should the rhythm become too rapid, we might see a decrease in cardiac output. We only treat these patients if they're symptomatic. We might give them atropine, but what we're really going to look at is the cause. If it's related to drugs, we want to make sure that we stop that drug and then watch the patient's heart rate and see if it improves. In this slide, you see the picture of the junctional rhythm. Up to this point, we've been talking about rhythms that tend to be fast. Now we're going to talk about some rhythms that tend to be slow. Although it is not always the case, it is with these rhythms that you're more likely to see bradycardia. The first is the first-degree AV block. From the P wave to the QRS complex. This is what we call a prolonged PR interval. Most patients with this condition are asymptomatic and don't need treatment. But as with all blocks, the ultimate treatment, if necessary, would be to pace the patient. The next block rhythm, it's also called a Mobitz 1 or a Winky block. In this rhythm, the PR interval just gets steadily longer and longer and longer until the patient loses the QRS. Again, most of the time these patients are asymptomatic, but if they do show symptoms, we can try atropine. It does not work very often. Most of the time this has to be treated just like any other AV block with pacing. This slide is the image of the second-degree AV block type 1, the Mobitz 1 Winky block. You can see P waves with QRSs, but you can also see a P wave with a blocked QRSs, but you can also see a P wave with a blocked QRS. Then the PQRSs start again, and then you'll see a lost QRS, and the pattern repeats over and over. This rhythm is the second-degree AV block type 2 or a Mobitz 2. It doesn't have a funny name like Winky block. It is P waves and QRSs Every QRS has a P wave, but every P wave does not have a QRS. It does not show that repeated pattern that the second degree AV block type 1 shows. So what does all this mean? We've talked about 3 different blocks up to this point: the type 1, the Mobitz type 1, and the Mobitz type 2. Each one of these can be symptomatic or asymptomatic, and each one of these, if they need treatment, can be treated with a pacemaker. Most of the time, patients are symptomatic with these blocks because they are bradycardic, and that bradycardia leads to low cardiac output. But the last block that I want to talk about is the third degree AV heart block, or complete heart block. Its most significant characteristic is that the atrium and the ventricle are pacing unrelated to each other. The atrium has its pace and are not associated with a QRS. The QRSs don't have a leading P wave. This rhythm is frequently associated with decreased cardiac output, ischemia, heart failure, and shock. We can attempt to use some drugs to speed up the heart while we're waiting the pacemaker, but the ultimate treatment for the picture of third degree heart block. Now, you may look at those QRSs and think, well, there's a P wave in front of them, and it appears that way on the graph paper. However, that P wave is not causing that QRS to happen. The P waves originate from their own conduction foci, and the QRSs originate from their conduction foci. QRS to happen. The P waves originate from their own conduction foci, and the QRSs originate from their conduction foci. You can tell by looking at this 6-second strip that this patient's heart rate would only be about 30 beats per minute. With that slow a heartbeat, it would not be at all surprising for the patient to complain of shortness of breath, syncope, and other symptoms because their cardiac output is so diminished. Now let's look at some ventricular dysrhythmias. The first one we're going to talk about is premature ventricular contractions. They usually are associated with some kind of stimulus, could be electrolyte imbalances, hypoxia, heart disease, response to medications, something like that. They're not normally harmful. In fact, almost everybody's had them at some point in time, but they can reduce cardiac output, lead to angina and heart failure if the heart is diseased. We want to watch their hemodynamic status and then, of course, correct any causes that we may see. Based on their foci, they can come in pairs that we call couplets. They can come 3 together, which we call a triplet. They can come every other beat, which we call bigeminy. No matter what they look like, we want to assess the patient's hemodynamic status to decide how much and what kind of treatment is needed. Another rhythm we might see is the accelerated idioventricular rhythm. We don't have a picture of it here, and I can promise you it won't be on your exam, but I just wanted you to know about it and that it's there. Atropine is the treatment if the patient is symptomatic, and if it's sustained, we would have to move to pacing. This is a picture of ventricular tachycardia. It kind of looks like a whole bunch of PVCs, which in fact it is. It can be monomorphic, which means they all look the same, as is pictured here, or it can be polymorphic, which actually the beats kind of leaned, which again means the patient just stays in V-tach, or they move from like normal sinus rhythm into V-tach and then back into normal sinus rhythm and then back into V-tach. We refer to this as having runs of ventricular tachycardia. Often these patients are symptomatic, and it's considered a life-threatening rhythm because it decreases the cardiac output and go into cardiogenic shock. It is also frequently seen as the precursor to ventricular fibrillation. This next slide is a good example of that polymorphic ventricular tachycardia. You can see that the complexes don't look the same. Poly, again, meaning multiple foci. This particular rhythm as shown in the slide has its own unique name, torsade de points, which means the turning of points. And although I previously mentioned that this is a life-threatening rhythm, the patient can be stable with the pulse and a blood pressure, but sustained V-tach, the signs and symptoms or manifestations that go along with that. The treatment goals focus on changing the rhythm and identifying the cause. When it's stable, we can treat it with dysrhythmics or cardioversion. If it's pulseless and unstable, then we begin CPR and go to defibrillation. The rhythm identified on this slide is concerning of all. It's called ventricular fibrillation. Ventricular fibrillation is when the ventricle is just in a chaotic state in which electrical activity is happening, but it's not organized enough to result in a contraction. The patient will be pulseless, and CPR and advanced cardiac life support needs to begin. Immediately. Care provider is able to witness the initiation of this rhythm. Immediate defibrillation is appropriate. Otherwise, CPR should be initiated and continue until defibrillation is available, and resume immediately after defibrillation. Medications will be given, including epinephrine and antidysrhythmic, with the goal of converting the rhythm and reestablishing perfusion. In this slide, we look at asystole. Asystole is an absence of ventricular electrical activity. It's sometimes referred to as a straight line, but the patient will be unresponsive, pulseless, and apneic. This rhythm is often seen with advanced comorbidities and has a very poor prognosis. It's treated with CPR, ACLS, but often results in no change and an end-of-life situation. Pulseless electrical activity is a rhythm that looks like it should be. It appears there is electrical activity going on in the heart with no mechanical activity to accompany that. The prognosis is very poor unless the underlying cause is identified and treated immediately. Once again, CPR is initiated and further treatment is directed specifically at the cause. This slide shows the cause. This slide shows you what's referred to as the H's and T's. The H's and T's are a mnemonic that allows you to think of all the possible causes for pulseless electrical activity, so treatment options can be reviewed and initiated. We can't talk about dysrhythmias without bringing up sudden cardiac death. We've already talked a lot about sudden cardiac death, but it is frequently related to underlying ventricular dysrhythmias, so it's worth mentioning again as a reminder. Prodysrhythmia is a side effect of antidysrhythmic drugs. Patients with severe left ventricular dysfunction have a higher risk for this phenomenon. Since it's more likely during the first days of initiating drug therapy, the patient should be monitored very closely for this possibility. So what are we going to do about these dysrhythmias? As I said before, the goal is to convert the dysrhythmia to an acceptable rhythm. We do this by either chemical conversion, or we'll talk about the drugs we can use for chemical conversion in the lecture on antidysrhythmics, but I've already mentioned a couple like lidocaine and amiodarone. So now I want to talk about electrical conversion, which we refer to as synchronized cardioversion or defibrillation. Defibrillation is the treatment of choice for VTAC and VFib. It polarizes the myocardial cells. This depolarization allows the SA node to kick back in as the primary pacemaker in the heart. It's most effective if done within 2 minutes of the onset of the rhythm. That's why early use of an AED is strongly emphasized in basic life support. You may still see monophasic and biphasic defibrillators used in the clinical environment. Monophasic defibrillators send energy through the heart in one direction, while biphasic machines send energy through the heart in 2 directions. This allows you to use lower amounts of energy and you have fewer post-shock dysrhythmias. This slide shows you a picture of a defibrillator. This happens to be a LifePak, but that's just one brand of many. Most defibrillators come with both monitoring, defibrillating, and transcutaneous pacing capability of patient. Well, first of all, most of the time the defibrillator is not going to be immediately available, so CPR should be initiated and continued unless you actually have the paddles on the patient and are doing the defibrillation. Once the machine is at the bedside, you're going to turn it on and select the proper amount of energy. More about that when we talk about synchronized cardioversion. You want to be sure some kind of conduction agent is used. It could be a gel that you apply or gel pads, but something goes between the skin and the defibrillator paddle. Then you will charge the defibrillator. Once the defibrillator reaches the desired energy, then you're going to say all clear, and you're going to press the button that allows the energy to actually be delivered. You do want to make sure that you position the pads firmly on the chest wall and hold them close as the energy is conducted. synchronized cardioversion to change a rhythm. However, we use it on rhythms that have a recognizable pattern and patients who have a pulse. The procedure itself is very similar to defibrillation. The difference is you engage the sync button on the defibrillator rather than make sure that it's turned off as you did with defibrillation. The energy levels are lower and the patient will be awake when you do this, so you might want to consider sedation. Patients can go from being a pulsed rhythm to a pulseless rhythm after a synchronized cardioversion, and in that case you would want to immediately defibrillate. You must remember though to turn that sync button off or the energy will not be delivered. Patients who have frequent dysrhythmias may be good candidates for an implanted cardioverter defibrillator or an ICD. This slide tells you some of the types. ICDs have been proven to decrease mortality. These devices are placed under the skin at the subclavian level, and the sensing system monitors the heart rate and the rhythm and delivers energy to the heart when it detects lethal dysrhythmias. This is an image of an ICD. On the right, picture number A, converter defibrillator. On the left, in picture B, you see where a subcutaneous pocket is made under the skin at the subclavian in which the device is placed. ICDs can work for both tachyrhythms and bradyrhythms, but be prepared for some concerns from your patient about having the device in place. Things about body image, fear of recurrent dysrhythmias, an expectation of pain when the device goes off, or anxiety about going home. There are support groups that are available for your patient in order to help them understand what to expect. In your textbook, Table 3511, and what to expect. In your textbook, Table 3511 gives you more information about patient and caregiver teaching for the patient with the ICD in place. You do want to emphasize the fact that they should carry a card that tells what the device is. They should have a medic alert ID badge on, and the caregivers should learn CPR. With the last few slides of this lecture, we're going to talk about pacemakers. As I said multiple times when we talked about AV blocks, first, second, and third degree, pacing is the treatment of choice for these dysrhythmias. It's also the treatment of choice for many instances of a paced rhythm. The small vertical line in front of the complex indicates the discharge of the pacemaker. Pacemakers can be set to pace the atrium or one or both ventricles. Pacemakers can be set to pace constantly or on demand. Demand pacemakers only discharge when the heart rate drops below a preset rate. There are also specialty pacemakers, anti-tachycardia pacing and overdrive pacing. These pacemakers are not common and designed to work on specific types of dysrhythmias. This slide is very much like earlier. The A picture is the device, and the B side shows how it's placed into the chest. Look particularly where the electrodes end up. This is a pretty good representation of how you would pace both the atrium and the ventricle. Biventricular pacing is used most common in cardiac resynchronization therapy. This is a kind of therapy that's used to treat heart failure. This is a picture of a temporary transvenous pacing device. Although the device is external, it's attached to wires that are placed into the heart through the vein. The next slide describes epicardial pacing. This is pacing that's done during open heart surgery, where the leads are actually placed directly on the epicardium. They pass through an incision in the chest wall and are attached to an external device. This is usually done prophylactically after open heart surgery. This kind of pacing is always for emergency needs. These are patients who are in bradycardia or in a block that are very symptomatic. It is non-invasive as the current is passed directly through the skin to the myocardium. It should be considered very short-term therapy and a bridge to a lot of patient discomfort. So we need to consider sedation in all circumstances where the patient can tolerate it. This slide shows how a temporary transcutaneous pacemaker can be attached to a patient. Pacemakers can also run into problems. Some of the most significant are failure to sense, failure to capture, or graphic representation of all three of these events. A is failure to sense. What's going on here is that the pacemaker is failing to recognize the patient's own rhythm and discharging when it should not. The arrows show the pacemaker discharging prior to the programmed rate. B is an example of failure to capture the programmed rate. B is an example of failure to capture. You can see a pacer spike that indicates that the pacer is discharging, but it's not sending out enough energy to cause the ventricle to contract. The last image, C, is failure to pace. Basically, the pacemaker is just not firing when it should. Pacemaker's just not firing when it should. As we care for patients who've had pacemakers placed, we want to monitor for complications, and they're the same kind you would expect with any kind of surgical procedure: infection, hematoma, and because the device is placed near the lung, there's a possibility of a pneumothorax. There can be atrial ventricular wires in, or the leads could be misplaced. Post-pacemaker placement care is pretty routine for a patient who's had an invasive procedure. Here you can see the highlights for patient and caregiver teaching for a patient who's had a pacemaker placed. They're very similar to those of the ICD. No MRIs unless the pacer's approved. Microwaves are okay. That's a misnomer a lot of people are concerned about. You want to make sure that the patient has the pacemaker ID card, a medic alert ID. Travel is not restricted, which is another misconception that many people have. Generators, and avoid anti-theft devices, as both generate a high electromagnetic field that can interfere with the pacer signal. Lastly, I just want to mention radiofrequency catheter ablation therapy. This is a therapy that's non-pharmacological, and it's used to treat was used to treat my supraventricular tachycardia. Note that the post-procedure care is similar to that of people who've had a cardiac catheterization. My own experience was that it was an outpatient